Good morning, or should I say good afternoon, Dr. Mateos. Thanks for joining us. We really appreciate you spending some time with us to share your insights in managing myeloma in the COVID area. The Spanish experience certainly is ahead of the rest of the world, and you can share a lot of your insights. We look forward to that. I guess the first question I want to get to then is just an overview of how you're approaching myeloma now. And I recognize that that has evolved over the last 3 or 4 months. So perhaps you can share your experience both early on and where you've ended up now in terms of caring for myeloma patients.
Thank you very much, Dr. Anglin, and thanks for this opportunity to discuss with you about our experience with myeloma patients during the COVID-19 pandemic. And exactly according to your question, the situation we are living right now is almost normal. So I will try to explain how we moved from the normal to the abnormal situation and now again to the almost normal situation. And you have to know that the pandemic in Spain basically started at the beginning of March when a lot of new cases emerged in our hospital. And you know that Spain has been highly affected by COVID-19. And in Salamanca is a small city, but we had over 1,500 patients admitted into the hospital by COVID-19. This put in context that our hospital was basically COVID-19, and we had to maintain our hospitalization unit as a COVID-19 free island in order to protect our patients. So our first goal was to protect our myeloma patients from the COVID-19, because at the beginning we had the idea that myeloma patients will be more vulnerable to the COVID-19 infections, and we had the feeling that maybe the mortality rate would be higher than in the non-cancer population. This has been something that we have confirmed, and I can comment about this later on. But in principle, we tried to maintain the disease under control. And for doing this, in newly diagnosed myeloma patients, if the patient was young, eligible for autologous stem cell transplantation, and the patient was newly diagnosed during the COVID-19 pandemic, we considered that the most important problem this patient had was the multiple myeloma. And we decided to start with active therapy. Our standard of care here in Spain is bortezomib, lenalidomide, and dexamethasone, and we decided to start with this therapy. But at the same time, we tried to optimize the circuit of the patient in the hospital. And for example, lenalidomide and dexamethasone, of course, oral administration and this drug were delivered at home. And concerning, for example, the bortezomib administration, every prescription was done in advance the day before, as well as the hemogram and the biochemistry, usually performed at primary care center in order to avoid long stays of the patients in the hospital. This meant that the patient was arriving to the hospital just directly to the outpatient facility to receive the sub-Q bortezomib, and in no more than 5-10 minutes, the patient was leaving the hospital. The rest of visits were done by phone. So we contacted with the patient the day before to check that everything was fine, that there was not any symptomatology suspecting the possibility of COVID-19 infections. And this is basically what we did with newly diagnosed myeloma patients with active disease. In the elderly population, the situation was more or less identical, but also we had the feeling that elderly patients would be even more vulnerable than the young population. And for these patients, we tried them to stay at home and to deliver oral medications if possible. And I have also to say that this was basically applicable to the pandemic to the weeks in which we had the peak of incidence by COVID-19. And this is applicable to the third, fourth weeks of March, as well as maybe the first week of April. And during these weeks, even some patients, for example, receiving daratumumab, lenalidomide, and dexamethasone, or daratumumab, bortezomib, and dexamethasone, we decided to skip daratumumab, but only in these weeks in which the peak was maximum, and we considered that the risk of infection was going to be significantly high. But outside of these 3-4 weeks, patients received the corresponding therapy according to the scheme of therapy that we had already prescribed, trying to protect them from the COVID-19 infections. And this is the reason why, from my point of view, it was even more critical for us to plan our organization and organization of the outpatient facility in order to reduce as much as possible the time the patients had to be in the outpatient facility. And this is, as a result of this, most visits were done by phone, avoiding the presence of the patient in the hospital, and the patient was coming to the hospital only for receiving the systemic therapy that we considered was necessary. Transplant was delayed because in these weeks it was not allowed to do autologous stem cell transplantation. But patients receiving induction, we decided to extend the induction therapy in 1 or 2 cycles. And fortunately, I can say that right now in July, all patients in which the transplant was delayed, they had already received transplant today. And I've seen today in my clinic some patients that received the autologous stem cell transplantation at the end of May or June. And now I can say that our situation from the patient's point of view is almost normal, although I think that we have learned a lot of things, and we are trying to optimize as much as possible the visits of the patients in our hospital. So from my point of view, it's critical to maintain the disease under control. And in line with this, I previously said that we have collected all data from patients in Spain with myeloma infected by COVID-19 and admitted at the hospital. And we have collected data from 165 myeloma patients, and we have compared the outcome with a similar series of patients with no cancer. And we have had the opportunity to see how the inpatient mortality rate is higher, 32%, versus 20% for the non-cancer patients. And again, we have observed how the advanced age, as well as the active disease and the renal impairment, were one of the most significant factors impacting in the inpatient mortality rate. And based on this, I think that young patients can potentially receive the appropriate therapy, whilst maybe elderly patients with renal impairment, they will be at higher risk of mortality if they become infected by COVID-19, and maybe this group of patients should be protected as much as possible from the infection by COVID-19.
Thank you very much for that comprehensive answer, Dr. Mateos. Can we just focus a little bit? You mentioned then the elderly patients, protecting them from COVID-19. So at present now, you're back to almost normal. Are you adjusting your therapeutic choices now because of COVID, or are you giving are you prescribing DRD or RVD as you normally would now in your current circumstance to transplant ineligible or transplant eligible patients?
Now we are prescribing the normal schedules of therapy, the normal regimes, and one of our new standard of care here in Spain is daratumumab in combination with bortezomib, melphalan, and prednisone, and we are prescribing the same regimes. We have also learned something about daratumumab, for example, because in the past, we prescribed daratumumab IV in the regular infusion, and now we are using daratumumab infusion in 90 minutes. We had not incorporated this new practice because we had sub-Q data in clinical trials, IV data outside of clinical trials, and now we decided to move directly to the 90 minutes infusion. The same, for example, for carfilzomib. We have some patients receiving carfilzomib, and we decided to move to the weekly administration. And some patients during the pandemic were receiving carfilzomib, dexamethasone, and daratumumab, and we decided to move to carfilzomib 70 or 56 milligrams per square meter, but just once per week. And this is something that we have maintained even after the pandemic.
Okay. Maintenance therapy. At this point, any changes to your views on maintenance therapy for myeloma patients?
No changes, but positive things we have learned from the pandemic, because patients in the past had to come to the hospital to receive lenalidomide maintenance every month, because it was not allowed for us to give the medication for more than 1 month. Now, due to the pandemic, it is possible. So patients are receiving lenalidomide and maintenance for a couple of months, what is much more convenient for them. And at the end, we are avoiding more frequent visits from the patients to the hospital. And I think that lenalidomide as maintenance should not be stopped by the pandemic, because patients can be at home receiving the oral medication with no problem. And at the end, what we have to try to do is to maintain the disease under control, because this is going to be critical in case of they became infected by COVID-19.
Bisphosphonate therapy, were you monthly or 3 monthly before, and what are you doing now?
Well, before we usually prescribed the bisphosphonates once per month until the disease is controlled, and once the response is achieved, we usually moved to bisphosphonates every 3 months. During the pandemic by COVID-19, honestly, we have avoided bisphosphonates in order to reduce the time the patients have to stay in the outpatient facility. And now, after the pandemic, we have restarted again the use of bisphosphonates. We explained to the patients that this was just a supportive care, and unless patients with hypercalcemia or something like that, we decided to forget bisphosphonates until the pandemic recovers.
Dr. Mateos, can you share with us challenges that you've experienced in terms of transitioning to virtual care in your myeloma population?
The virtual care for myeloma patients during the COVID-19 pandemic has been something extremely positive from my personal point of view. Before the pandemic by COVID-19, we did already some phone call visits to the patients, because you know that the disease evaluation, the response of the disease to the treatment sometimes is not available on the same day the patient was coming to the clinic, and we had to call them in 1 week time, just in order to inform them about the results and to say you can be comfortable because your disease is in complete response or you continue in partial response. And once the COVID-19 arrived to our lives, we have to do much more phone call visits to our patients. This has been something extremely well evaluated by the patients, because they were worried for coming to the hospital, because the news they heard was the hospital was completely full of patients with COVID-19. There is not any other patient in the hospital beyond COVID-19, and definitely they didn't want to come to the hospital. So we decided to start with these phone call visits, and they included a phone call in order to ask how the patient was, how was their general performance status, as well as also the potential COVID-19 related symptomatology. If the patients were receiving oral medication, what we did is to order the medication to be delivered at home. So this was something extremely convenient for the patients, and this is what we did during the months March, April, and even May. We had been ordered oral medication at home. For patients for which it was necessary them to come to the hospital to receive the systemic medication, we did also phone call visits the day before, just in order to check that everything is fine. And even we suggested the patients to go to their primary care center in order to do the hemogram and the biochemistry. So we checked the same day of the phone call visit, and if everything was fine, what we did was immediately to prescribe the medication. And when the patient was coming to the hospital the following day, they were directly to the outpatient facility, they received the medication, and immediately they left in order to reduce the time the patients were at the hospital. So in summary, I would say that the virtual care, the phone call visits had been something positive for us as physicians, but also for the patients. And now I think that we can potentially to combine, and maybe we are going to do more virtual care for some patients with problems, for example, for coming to the hospital every month or maybe twice per month.
I know you've reflected, in Canada, we reflect the same thing. We're definitely going to more virtual visits post-COVID with all the checks and balances in place. How are you approaching COVID testing in asymptomatic patients that you are seeing in your myeloma population?
This is an important question, and it has been a topic of great discussions here, because especially for myeloma, because it is well established that newly diagnosed myeloma patients should be tested for COVID-19 before starting therapy, no doubt. The same for patients before peripheral blood stem cell collection, before autologous stem cell transplantation, or before the admission into the hospitalization unit by whatever reason, because we had always to maintain our hospitalization unit as a COVID-19 free island. But the problem is the regular patients that, myeloma patients usually require the treatment every week, sometimes twice per week. So it is not practically affordable to do COVID-19 test before every administration. So what we had is just a checklist with the most common COVID-19 related symptomatology, and patients had to complete this checklist before coming to the clinic. And if everything is negative and they don't present any COVID-19 related symptomatology, they come to the hospital, they receive the medication, and in myeloma, we are not doing COVID-19 test for every patient before every administration because this is not affordable.
COVID positive population myeloma patients, you've had some experience with this. Can you share some of your experience, Dr. Mateos, with that group, the COVID positive myeloma patients?
Yes, well, as I previously said, in Spain, we had collected data from 167 patients with myeloma infected by COVID-19. And in Salamanca, we had approximately 11 myeloma patients infected by COVID-19. The experience has not been very good, unfortunately, because the mortality rate has been quite high. And in fact, approximately 36% of the myeloma patients finally died because of the COVID-19. But it's true that some questions remained unanswered once patients recovered from COVID-19. For example, when to restart therapy. We didn't know, and we decided to wait approximately 2 weeks before starting therapy anti-myeloma again, just in order to protect the patients. I remember an elderly patient with myeloma that she had received just the first cycle of DARA plus VMP. Just with one cycle, fortunately, the patient had responded very well. She was infected by COVID-19. She was hospitalized for approximately 7-8 weeks, but finally the patient was discharged. But the problem were the post-COVID symptomatology because the patient had some respiratory problems. So before restarting again the therapy, we decided to do pulmonary test in order to check that the pulmonary function was normal, as well as also a cardiological evaluation because well, the patient was not completely fine. Fortunately, the patient was fine, and she has started again the therapy just 1 week ago, and the patient is fine. So we don't know, and as you know, all societies, all cooperative groups did a lot of recommendations, and I always say these are recommendations because nothing is evidence-based. Now we have analyzed our myeloma patients. The International Myeloma Society will publish very soon also a large series of myeloma patients around the world infected by COVID-19. And I think that what we have to do is maybe to revisit these recommendations after the evaluation of all these large series of myeloma patients in order to put in context how to proceed in case of new waves and so on.
I think the Canadian experience is largely mirroring what you've experienced and what you're doing in Spain in terms of more virtual visits, getting back to what standard care is, but more virtual interactions, less time in the cancer center. We're conscious of all of that. And then the role of COVID testing, which a lot of us are now using judiciously, doing it at least once in patients going on therapy. Yeah, I see a lot of similarities there with the Canadian experience. Dr. Mateos, we want to thank you very much for being with us today. We appreciate your time, and we look forward to you sharing your experience and the Spanish experience specifically with regards to COVID and caring for myeloma patients.